All right. Very exciting session. I'm so thrilled and I'm having a lot of fun. Our next speaker, Dr. Brian Dornbos, is an optometrist from Grand Rapids, Michigan. He received his bachelor's degree in vision science and his doctorate of optometry from the Michigan College of Optometry at Ferry State University. And he completed his residency through the Department of Veterans Affairs prior to joining Vivid Vision in 2017. He is a clinical instructor for multiple optometric colleges and has lectured at the Council on Optometric Practitioner Education. He currently serves as the Chief Compliance Regulatory Officer for Vivid Vision, which is doing really amazing work with virtual reality, which he is going to tell us about. Without further ado, let's welcome Dr. Dornbos.
Well, it's a pleasure to be here among some great minds, and down here in Hawaii, I think I'm about 5 pounds heavier thanks to all the poke that I've eaten. And now understand why the Hawaiian shirts are tight on top and very loose around the middle section. Again, as Dr. Odaibo said, I'm Brian Dornbos, the compliance officer for Vivid Vision. What that means is I get to do all the terrible paperwork that no one wants to do. As a disclosure, I am vested in Vivid Vision. What we're going to talk about today is a little bit different than some of the AI and the excitement around that, and focus a little more on a different acronym of VR, virtual reality. Have many of you had a chance to try a virtual reality headset or maybe play a game? It's something that's relatively new and has come into vogue over the last few years. And what's really intriguing is virtual reality has an incredible application across all fields of healthcare. This could be in the educational setting, in a classroom. It could be in the surgical suite, where someone's learning how to do cataract surgery in a virtual environment. And then from the patient side, from an education standpoint and also from a treatment standpoint. What we're doing at Vivid Vision is we're going two different routes, and what we'll talk about today is using virtual reality for binocular vision rehabilitation, but also we're able to use this for, say, measuring perimetry, looking at exciting things in low vision. When I talk about virtual reality, it's a bit of an alphabet soup. Virtual reality on the left-hand side of the spectrum is essentially a computer-generated image where the player or the patient interacts in a completely computer-generated environment. On the opposite side of the spectrum, as we look at something like Google Glasses, we have augmented reality, where we're using now the real environment and inputting a computer-generated image somewhere in that real environment. If you think of, say, a Snapchat filter, that's a small example of augmented reality, or the Pokemon Go game that was fairly popular. Somewhere in the middle, we see something like the Microsoft HoloLens, which has a little more computer generation and uses a little more of the real environment. And just to make things more complex, now this whole set is being called XR, or extended reality, and that catches all of these. The core concept of virtual reality, if we think of it as either a gaming standpoint or the way that we use this as a treatment, is immersion. And how do you get immersion? Well, you need to stimulate the senses as best possible. In the critical sense, of course, for something that's head-mounted and the patient's using their eyes would be the sense of sight, in this case, a binocular environment. The patient needs to use both eyes together and be able to orient in space. If a patient moves forwards or backwards and vestibular input changes, the visual world needs to move appropriately so that a patient doesn't become motion sick. The next item would be touch, having a player or a patient be able to move around, orient, grab something, pick it up, look at it in virtual reality. And then sound, use of auditory feedback, some cues to tell a patient that they've interacted with an object. What's a little more difficult, of course, would be smell or taste. There are some interesting companies that are out there trying to work with face-mounted masks to use smell and wind and just get a feel for a little more immersion in a game. So all of these, best possible, specifically sight, touch, and sound, are going to be incorporated into a virtual environment to help patients feel immersed and then rely on engagement. Now, as physicians, you definitely know that patient engagement in therapy is paramount. I'm sure you've all seen the glaucoma patient that just doesn't want to take their eye drops. We need to have a patient that actually buys into their therapy, be it an eye drop, a pill, or some sort of physical or rehabilitative type of therapy. We think specifically about improvement of vision. There's three core components that the visual system can actually be influenced with. The first is cortical suppression or suppression. This would be for patients with amblyopia or strabismus. Along with this would be the ability to strengthen fusion ability, say a patient that has convergence insufficiency, divergence excess. And then for a patient with amblyopia, also improvement of visual acuity and stereo acuity. All of this, the goal would be to improve the patient's quality of life. So specifically with virtual reality and vision, what can we treat? We can treat specifically amblyopia and strabismus. Often these two go hand in hand. We may have patients that have refractive amblyopia, anisometropic amblyopia, a strab, and then a mix of amblyopia where we have a little bit of both. And then patients with vergence disorders. Most commonly would be convergence insufficiency. That's about 10% of the population. That would be the inability to maintain a clear, comfortable image when directing both eyes at a target. The treatment first steps are always the same. We still need to place a clear image on both retina. So we'll use glasses, correct optical blur, equalize accommodation between both eyes, and then long-term keep a clear image on both retina to promote vision. When we add a VR headset, we now take this slightly different from the traditional penalization therapy of patching or atropine, which treats the visual system more as a set of two monocular systems versus now shifting to treat the visual system as a binocular system. This can be used in two different ways. This can be for patients that have done patching therapy and perhaps hit a wall, patients that were non-compliant. The other way is to start out early and promote use of both eyes together using these dichoptic or split environments. To translate VR into vision rehab, the whole of this falls under perceptual learning. Use of a small task or gamified task in our place to improve over time and focus on one visual skill and then extrapolate that to the next and the next and the next. We can use that with vergence. We can force the patient to converge or diverge, add stress as if we were adding, say, a base in or a base out prism. Focus on stereopsis. Build on the use of disparity cues over time and have the patient learn how to use stereo cues and improve their depth perception. For patients with amblyopia, again, a critical item would be improvement of clarity of vision or visual acuity. This anti-suppression, MFBF, and dichoptic presentation is something that's not all that familiar to a number of eye care providers. MFBF stands for monocular fixation in a binocular field, and the term du jour now is actually dichoptic image presentation. What this means is there's a split image between what the right and the left eye sees. So if we're playing ping pong, one eye sees a set of paddles, one eye sees a ball, and then the environment would be a binocular field. Now, the change between MFBF and dichoptic is actually adding, say, a dark filter, a neutral density filter, or a blur filter over what the dominant eye sees to give the patient's weak eye, weak amblyopic channel, a sharper, clear image. And again, all this wraps up nicely into perceptual learning and weighting any of these tasks in a virtual reality environment or game. More traditional anti-suppression environments. Does anyone have a major amblyoscope or a synoptophore in the eye clinic? They still make these, it's a little more common in Europe. If you're familiar with this, the synoptophore uses these mobile arms. I laughed that you were using the bird in cages. That was one of the slides that I always remembered from the synoptophore, was a bird in a cage shown to each eye, and the goal was to keep the bird in the cage. And then some red and green glasses can be used with a chart similar to this to help a patient learn to use both eyes together. A little less exciting than when you place the patient in a gamified environment where now we have a task, say a basketball-like task where the patient is catching a basketball in a basketball hoop using this stereo environment in the background. There's a bit of a paradigm shift in the way that suppression for amblyopia and strabismus is thought of now. It used to be that once the patient hits a wall, the critical period in about adolescence, that there's just not any chance for improvement once the patient hits that. I worked in the VA for a number of years, and most of the time we'd see these patients that were diagnosed with amblyopia maybe at a later age, and we're told there's nothing that can be done beyond that. The thought now is that it's not that the visual system has completely lost the ability to use both eyes together, but that it's been suppressed, it's been reduced, but these binocularly tuned neurons still exist, and the pathways just have not been used. That's the goal of what we're trying to do, is have the patient learn how to use these weak pathways and use neuroplasticity to help build up the ability to use both eyes together. The excitement is that we're seeing patients improve 1, 2, 3, 4 lines in visual acuity. Often these are older patients that have had some form of treatment beforehand and may not have the opportunity to try any type of treatment due to just their age themselves. The key component to all this is visual attention is very important. The patient has to be engaged and actually participate in the theory. That's the whole concept behind, again, perceptual learning. Just to give you an idea of what it looks like in a VR headset and how we would use, say, a very simple task to help break suppression and have a patient use both eyes together. Here we have a left eye that's weak, the right eye that would be the dominant eye, and we can adjust, in this case, the albedo ratio of a cube and start to adjust how the cube is perceived between the right and the left eye. When we make these changes, this suddenly makes the cube pop out in 3 dimensions for a patient that is only using one eye, or the majority of their vision out of one eye. Very simplified breakdown of what this looks like from a VR environment will change the brain for a screen. Under normal conditions, a patient converges their eyes on a single image. The image then becomes clear and single and interpreted by the brain as one single bird. The problem, of course, comes with, say, a patient that has strabismus, where one eye is incredibly deviated off to one side. This is incredibly confusing for the visual system. We have a macula that's pointed at one red bird and another macula that's pointed off at the blue bird. Due to corresponding retinal points, we now have the visual confusion of a red and a blue bird overlapped on one another. And since both eyes are still using vision, we have also diplopia, where the birds are seen doubled. So the brain's fix is simply just ignore what's happening in the deviating eye. So what can VR do for this? For example, with our same patient, we'd start out by moving where the actual image is placed to match up with the patient's deviation. Say this is a 50 prism diopter exotropic patient, we'd put the image exactly out where the patient's angle of deviation is. And then over time, we'd slowly reduce where the image is placed as the patient works on the ability to bring their eye back straight. This has application in 2 ways. For some patients, your intermittent exotropia patients are usually fairly easy to deal with, as they're a convergence type movement. Some patients also that are strabs, you can work with them at their angle of deviation, perform strabismic surgery, and then continue to work on building the binocular skills over their ability. It's a wonderful combination of working from a rehabilitative standpoint, working with the surgeon, and then continuing rehabilitation from there. How do we do this in a gamified environment? We split the scene again. We give the patient a task for the best seen eye, so say the spaceship and the 2 rings. We give the patient the binocular environment of the space background. We give the patient a fusion target that is linked between the right and the left eye, and then give the patient a set of targets that is only shown to the weak eye. So in this case, the up and down, the up chevrons. And then give the patient a task, say only go through the up chevrons that are blue. So we know the patient is actively participating if they're only flying through the blue chevrons versus the red. If a patient suppresses, then you need to make a small change. We can do this by adjusting the size, taking a target that's small and making it really big, overwhelming the size of the suppression scotoma for a patient, or adjusting pieces of the scene or the entire scene by applying a dark filter or a blur filter over the image that the dominant eye uses. Once you break through suppression and start to get the patient to use both eyes together, you can work on stereo tasks, using these small offset targets to use disparity cues to see targets. The whole goal of this is changing the signal strength so that the patient's amblyopic eye gets the sharper, brighter, clearer image versus the dominant eye, and then slowly taking away the help that we've given the patient over time as they equalize and learn to use both eyes together. Just to give you an idea of what this looks like with the same setup in a VR headset, here we actually have 3 degrees of fusion, simultaneous perception with the up and down chevrons and the spaceship in the right eye, the flat fusion target of the white rings, and a stereo target of the asteroids. Making changes, we can change the size, change the contrast of pieces of the scene, blur out the dominant eye or use a dark filter. And if we have a patient that has a strabismus here, I've added a whole bunch of base down prism to the patient's left eye. You can see if you watch the horizon on the space background, it's significantly higher. The next stage, this is one that it's very difficult for us to see if we're looking at this as a flat target, but this would actually be a depth perception challenge where the patient's essentially repeating a stereo task again and again. If you say the Wert ring stereo test in the office, where you have essentially 4 different trials, here we're repeating a stereo task again and again and again. What's really exciting is we're seeing improvement in patients that, again, we're told that there's not much improvement or not much that can be done. We used dichoptic therapy in an adult cohort of amblyopic patients and found that there was a significant improvement in not just visual acuity, but also stereo acuity in patients that had undergone previous treatment, had been wearing eyeglasses, and were now in the third, fourth, or fifth decade of life. We saw the same information looking at a cohort of patients that were from age 3 to 69 and saw, again, an improvement of about 2 line gain in visual acuity and saw a significant improvement in stereo acuity as patients went through a therapy setup. All this is dictated by the physician, so it's not just that a patient goes out and buys some type of equipment, but this is actually changed and updated by the optometrist or the ophthalmologist while they're doing and progressing through therapy. The biggest difficulty that still has not quite been overcome is the vergence accommodation disconnect in a headset. There's actually a fixed accommodative point in a headset where we're altering vergence demand, but we don't have a change in accommodative demand, at least not very much. And our goal right now is to work forward to randomized trials on a large scale to look at how patients improve over time using technology like this. So thank you for your time.
Questions?
Thanks so much. That was really great. I think theoretically it could probably help some patients with macular degeneration and help them with eccentric viewing, looking concentric. But my question is centered towards kind of like catching the problem earlier. You know, there's great solutions out there. I think companies like, you know, Google have AIs that can detect 50 different eye diseases or even heart problems, and you know, various solutions. But when it comes to, you know, detecting the problem early, you know, where's the pipeline? How are you finding your patients? You know, how early?
That's exactly it's an item that we're not personally working on right now, but something that is very critical to this. In fact, we could do a lot for amblyopia therapy if we would catch the patient incredibly early. If every single one of us made sure that we saw patients at age 1, 2, 3, 4, caught the early eye turns, caught the early anisometropic patients, that would be critical to reducing this problem. And quite honestly, I'd be happy to be out of a job if we could catch and reduce amblyopia like that.
So I had a chat with last year, and over a period of I think 2 years, we were able to screen around 100,000 patients, screening for diabetic retinopathy by deploying smart cameras at local eye doctors. Is there something? Is that model something potentially leverage, or is that something you're thinking towards? Because again, I see a huge need to catch the problems early, because when you catch it early, you can intervene, right, and save the patient a lot of headache.
Exactly.
Right? I'm the number one patient. So.
No, exactly. It's early detection that's critical, and that's what I love hearing about all of these different either AI or telemedicine groups, is the ability to catch these problems early, specifically in our case in the pediatric population. Kids can sometimes be difficult to work with, and it's hard to screen. And sometimes practitioners are a little scared to see kids, to be honest. There are great ways to detect. There's a company called the name's escaping me. They'll do just a simple autorefraction check, and they're able to detect eye turns and also inequalities between the right and the left eye. Something simple like that could be rolled into say a primary care office or a pediatrician's office would be wonderful for screening. And then the goal would be to pass that on to the eye care practitioner that can handle the problem as early as possible.
Thank you so much for that lecture. And just speaking to what you were talking about in regards to your business. So first and foremost, the affordability of this service, I just wanted to know, just because I service a lot of low payers, so I just wanted to know how they would be able to gain access to this, and I guess the most affordable way. But also secondly, kind of even for myself, because I mean, thinking back into medical school, the amount of time I personally lost over intermittent exotropia, just because I always have to refocus every couple of minutes. I mean, I had it pretty well, but now until I got, assistance to try and actually converge and actually fix the accommodation of both my eyes, it was a little difficult, and I mean, just time consuming for myself.
Yep.
So I mean, just not even for my patients, but even for myself, just thinking about ways that I could have used this way back when, for commercial payers and low payers, what would be the best way for us to access the service like this?
The way that we do this at the moment, the critical item with amblyopia is a correct diagnosis. So this is not something that a patient just goes out and buys and says, here you go, treat yourself, good luck. We do this through either physician or optometrist. So it goes through a provider that provides an eye care, that's an eye care provider, and then that treatment plan is built at the moment by the physician or by the optometrist. So it runs through a provider that offers an eye care service and then offers our Vivid Vision service in their office. This is based as a clinical unit, if someone is coming into the office on a weekly basis, perhaps for therapy, and then a home-based unit, which a treatment plan is built and then provided. So someone like you in medical school, it would be more a home-based treatment where a plan would be built on working at your abilities to start and then slowly challenging you over time to work on convergence, to work on divergence, et cetera.
And so could we ideally get, if we wanted to use in a primary care office, because I am primary care myself, would it be possible that someone could come in and train us, or even have someone that could come in and maybe just train all staff, and then maybe just intermittently for those that need that eye service can just possibly be evaluated at the point of
No,
care?
that's exactly the long-term goal with this, is to make it so user-friendly that anyone that's, when I say binocular vision to a crowd of eye care providers, if it's ophthalmology or optometry, usually I get some really wide stares. It's a little scary sometimes. And again, then you add on that I'm talking about pediatrics and people fall out of their chairs. But that's the ultimate goal, is to make it so user-friendly and just the concepts behind the treatment that we're giving to be so usable that a primary care provider, eye care provider, could utilize this in the office and build a plan for a patient very simply. You bet. Thank you.